So I know that was a lot to sort of take in, but really want to sort of highlight really that what the goal is to have an easy bedside way of how we ask a couple of questions about assessing for depression. It's important to do this in patients with cancer because a lot of people have symptoms of depression. But what I want to do now is talk more practically about what do we do about it? How do we manage these symptoms, and what are some of the tools that we can use to do that? And so the fourth point here will be the management of depression in cancer patients. So one of the things that we try to do is to prevent depression or prevention, and try to focus on ways that we do that. And I would be remiss if I didn't talk about the fact that there's good evidence that, particularly in patients with things like advanced lung cancer, that involving a palliative care team or practitioner earlier in people's disease course has an improvement in their symptomatology. And so this large trial that was done in Boston in the United States, looking at advanced cancer patients, when just having a patient meet with a palliative care specialist showed that at 12 weeks of their intervention, and so the PHQ-9, which I talked about here on the right, which again is a depression tool, showed that early palliative care interventions and seeing a palliative care specialist or a team to focus on helping with symptoms of depression improved patients' depression symptoms at the 12-week mark in this trial of patients with advanced cancer. Just the presence of somebody coming in and talking about patients' symptoms, assessing their psychological distress, spiritual needs, actually is a depression intervention. And actually, this trial gets a lot of news for the potential for palliative care improving people's survival. But the reality is that actually most of what palliative care can do is actually to help address a lot of the psychological symptoms that patients with things like advanced lung cancer may be experiencing. So I want to highlight that just involving that sort of a team can be really impactful in the quality of life of your patients. Really what gets me up in the morning is thinking more about the treatments and the medications that we might be able to provide to sort of target symptoms for patients. And so I show here a couple of synaptic connections here to sort of highlight the role of serotonin in treating major depression. And I'm going to talk about two classes of medicines, in particular the SSRIs, or the selective serotonin reuptake inhibitors, or the SNRIs, or the selective serotonin noradrenergic and norepinephrine reuptake inhibitors, as the primary treatments for addressing these sorts of symptoms. Now, depending upon where you work, there's access to different medicines. I've done work in sub-Saharan Africa, in Kenya, in Eldoret, done some work in Kampala, Uganda, and not everybody has access to this large armamentarium of pharmacotherapy. Oftentimes our formularies can be very small. Different health systems and patients in particular can't afford this sort of cornucopia of medications. And so how do we sort of decide really what's the best medications to give, particularly to patients who have cancer or other serious illnesses where they may be on a lot of other medications, and we may be concerned about drug-drug interactions. One of the things that I find that's really important is to pick a medicine that's going to work, that's going to be efficacious, and a medication that's people are actually going to take after you prescribe it, meaning that it's not going to have a ton of side effects, and it's going to be something that's going to be inexpensive and easy for people to access. And so you want to pick medication that has efficacy, and what I refer to here is acceptability, meaning that they're going to actually take it after you prescribe it, and it's going to help and not have too many side effects. And there was a large trial that was published in The Lancet in 2009 that tested a bunch of different antidepressant medications against each other. This is a little bit of a busy slide here, but it shows that around the time that this trial was done in the late 2000s, there had been sort of the most clinical trials for Prozac or fluoxetine, or paroxetine or Paxil, sertraline, which is also Zoloft, but compared all these different medication trials against each other to look at this outcome of efficacy and acceptability. And what they found was that two medications of that cohort sort of kind of rose to the top. And so sertraline or Zoloft in our system was the lowest cost at that time, was efficacious, and was acceptable to patients. They were less likely to discontinue it and had the lowest side effect profile. And then escitalopram or Lexapro, which is an enantiomer of citalopram, also had efficacy and acceptability, and at that time, those two medications were the ones that really were probably the best of the comparators at that time. Now, other medications have been approved since then, but honestly, really, there's not been any medications that have come out that have really been better, more efficacious, or more acceptable than these two medications. That being said, those two medications can be really helpful in your armamentarium, and I'll talk a little bit more about other treatment recommendations. But when we take into consideration that sort of question of acceptability, that can be very specific to different patient populations. And so before I talk more about sort of my recommendations for medication selection in the context of thinking about efficacy and acceptability, I really want to talk about the side effects because that's what most patients are concerned about. The biggest one, and when I teach my students and residents, is really the stigma associated with having a diagnosis of depression and the stigma of maybe taking a medication for that. Some people will see this as a personal failure, will think about this in the context of their faith or spirituality. And the biggest thing is that a patient is really only going to take a medication if they think that they have a problem and if they want to do something about it. And for a lot of our patients, they may want to just meet with somebody to talk about how terrible it is to have a diagnosis of depression. So an intervention like psychotherapy may be much more acceptable and efficacious to a patient than any medication ever will be. Just having a good rapport with a primary care doctor or an oncologist may have far more power for them than taking any medication. And so it's really important, in particular, anytime you prescribe a medicine, that you know the side effects of those medicines, because if people aren't given a warning shot that they may have certain side effects and then they experience those, they're less likely to take it, and that medication is really not going to be helpful to that patient. And in particular, these classes of medicines can have some intolerable side effects. Most commonly, these medications have GI side effects or gastroenterologic side effects. I will tell you that GI side effects can sometimes actually signal that these patients might actually have a larger benefit from that medication. So the enteric nervous system, or the gut, the lining of the gut, the columnar cells that are in the small bowel contain a lot of serotonin. And so when you swallow a pill like Prozac or something like Zoloft, that increases the levels of serotonin in the gut lining. And when it does that, that increases nausea, it increases diarrhea, it increases people's risk for vomiting. So you really want to go low and slow with the medication and start at the lowest effective dose to avoid a lot of GI side effects. There is some tachyphylaxis or some tolerance to those side effects. So I tell patients that generally this might go on for a week, and then it usually gets better and goes away. And it doesn't usually occur again if we increase the dose relatively slowly. The way that I help my students remember this is that medications that block serotonin, like things like ondansetron or the cetron class of drugs we use for chemotherapy-induced nausea and vomiting, help with nausea. So if you block serotonin, you help nausea. But things that increase serotonin, like the SSRIs, will cause nausea and vomiting. So this is sort of more of a pharmacologic side effect than some other specific side effects. Some of these medicines, depending on the class, particularly like the tricyclics, things like amitriptyline or triptyline, can cause dry mouth due to the anticholinergic effects. Some patients can almost get some akathisia or feeling restless, or if they have anxiety, some of these medications are intolerable. And one of the things that we spend and want to counsel patients about is there are GU or sexual side effects related to these medications, and they can lead to significant risks of people not taking them if it affects their intimacy with their partners or their spouses. More uncommon problems, particularly citalopram, can lead to hyponatremia, serotonin syndrome. So medications in combination are risk factors, and this is generally dose related. So higher doses of medications or combinations can lead to serotonin syndrome. Patients who might have bipolar disorder can become unmasked with one of these medications. So most patients with bipolar illness will usually have a depressive episode first, and if they get started on an antidepressant, that may then sort of shift them into mania. There's a risk of increased suicidal ideation generally in children and adolescents. What I worry about with one medication in particular, bupropion or Wellbutrin, is the risk of seizure or lowering seizure threshold, particularly in patients with cancer who might have brain metastasis. So for my patient, we would never use bupropion or a patient with a brain tumor because it would increase their risk of having a seizure. There's also increased risk of GI bleeding with SSRIs and SNRIs. The serotonin burst is part of the coagulation cascade, particularly with platelet aggregation. So in older patients, particularly those on like aspirin for heart disease or who are taking non-steroidal anti-inflammatory drugs, the combination of an NSAID in an older patient on an SSRI actually can increase their risk of bleeding about 2 times above other normal controls. And very rarely have I ever seen an anaphylactic reaction to these medications, but it's listed in the package inserts for a lot of these drugs. So we've talked about some of the bad things that can happen, but always whenever you're giving a medication, you want to weigh the risks and benefits. And hopefully if you're treating somebody with severe symptoms of depression, likely the benefits of these medications will far outweigh the potential risks. And usually, again, the gastroenterologic side effects of nausea or diarrhea tend to go away and tend to be very mild in most patients. However, if you're having nausea, vomiting, and diarrhea from chemotherapy already, starting one of these medications may not sound great to one of your patients with cancer. So how do I pick medications then, given potentially a lot of choices for treating folks with cancer? Well, I try to know a few drugs, and particularly those that aren't going to have a lot of drug-drug interactions with medications that they're getting for, say, chemotherapy for patients with cancer. But for other folks who have serious illnesses who might be on lots of other medications, we have to be careful about drug-drug interactions. And so part of the medications I'll list here are drugs that have low likelihood of having like cytochrome P450 interactions with other medications. So here, and I'll be hopeful to hear from you all about what your medications you have access to, particularly on your formulary that you use, and would be happy to sort of focus on those medications if the ones that are listed here aren't medicines that you have access to. But our recommendations across the cancer world are to try to use medications in the SSRI category, particularly sertraline or citalopram, have very low drug-drug interactions. Again, sertraline in that Lancet trial showed good efficacy and low side effects and tolerability for patients. So I generally start with that. Start at 25 milligrams and then slowly double the dose until I get to about 100 milligrams a day. Citalopram or escitalopram, it's an enantiomer. I generally start at 5 to 10 milligrams and work my way up. In the SNRI category, venlafaxine or Effexor, it's probably the safest and most efficacious with the lowest drug-drug interactions. And for patients who have pain, that noradrenergic side effect of venlafaxine can be really helpful for neuropathic pain. And if you have a patient who has insomnia and depression, mirtazapine or Remeron is probably your safest and probably most effective medication for patients. We started at night due to the sedation side effect of this. At the bottom, I highlight that we generally try to avoid tricyclic medications, so fluoxetine or Prozac or paroxetine and Paxil. We try to avoid these as first line for patients with cancer, primarily because of the drug-drug interactions with chemotherapeutic agents, but also because of some of the anticholinergic side effects that can cause dry mouth, constipation, and difficulties there with the side effect profile.